Good evening. Welcome, everyone, and thank you for joining us for our session this evening. And it's a great pleasure of mine to get to introduce one of my, and she's going to get mad at me for this, but one of my absolute nursing heroes. I always fangirl a little bit when I get to introduce Diane. So for those of you who don't know me, my name is Kimberly LeBlanc, and I'm the academic chair for nurses specialized in Wound Ostomy Continence Canada. And it's my absolute pleasure to introduce you this evening to Dr. Diane Krasner. Dr. Krasner is a board-certified wound care nurse with over 35 years of experience in wound ostomy and continence care across the continuum of care. She's a fellow of the American Academy of Nursing, a fellow of the Association of the Advancement of Wound Care, and a master of the American Professional Wound Care Association. And I would like to also give huge congratulations because as of last week, Diane is also one of the inaugural fellows of the Wound Ostomy and Continence Nurses Association in the United States. And that's a huge, huge feat, and we wish you great congratulations, Diane, for becoming one of those inaugural fellows. Diane is a wound and skin care consultant, educator, and expert witness. She's a member of the Coalition for At-Risk Skin, or CARS, and one of the founding members, and of the Post-Acute Wound Care and Skin Integrity Council, or PAAWC. As of November 15th, Dr. Krasner is serving as a senior advisor for CARS, and from March 2023 to December 2023, she is serving as the interim past president for PAAWC. She serves on the National Pressure Injury Advisory Panel, Standards Committee, and the Negative Pressure Wound Therapy Subcommittee. Diane has a long and distinguished proliferative publication career. I'm sure many of you have read many of her articles, book chapters, and all of the textbooks which she has edited as well. So with great pleasure that I introduce you to Dr. Diane Krasner. Diane, welcome, and thank you so much for joining us.
Thank you, Kim. Thank you for that nice introduction. Kim and I were actually together last week at the WOCN next meeting in Las Vegas. It was a great meeting, and so I am very happy to have this opportunity to share with you some of the work that the Coalition for At-Risk Skin has done, and I thank FAAWC and Medline for this opportunity, and Medline for sponsoring the initial 2 years of the coalition. So I'm going to see if I can share my screen now. And yeah, perfect. So when I was getting ready to present this last half hour, I was thinking about the very first webinar I ever did, which was in the mid-90s with Kathy Harley, who many of you certainly know her name, if not know her. And it was across Canada. And it was such a exciting thing to be able to do. And of course, now here we are, fast forward past the pandemic, and doing webinars and sitting at your computer in your living room is like second nature, although it still makes me pretty nervous with all this technology, but hopefully it will cooperate. So I am in York, Pennsylvania, where I've been for the last 22 years. And prior to coming to York, I was in Baltimore. I worked in acute care hospitals, long-term care when I got to York, home care. So I've had a broad range of experience, and certainly dealt with patients with at-risk skin all along the continuum, although we never had that language to use in the early days. So when Medline initiated a long-term care advisory board, and I was one of 12 members on that advisory board. And that's how this whole thing got started. So I'm going to be telling you a little bit about how we got started, what the issues that we saw were, and then how we developed this consensus document. So I want to just begin with a few disclaimers that I serve on the Medline Post-Acute Care Advisory Board, and I'm also on the MAPWCA Speakers Bureau. The focus of the Coalition for At-Risk Skin in this presentation and the recommendations given are limited to topical skin health, prevention, and management. But we recognize that holistic patient care is required in all circumstances to optimize skin health. And you can ask me that in the Q&A if you want to. Members of the CARS panel were not paid by Medline Industries for the writing of the document that we're going to share with you tonight. So I have three objectives in our time together. First, to have you understand the background of the Coalition for At-Risk Skin and how the At-Risk Skin consensus document came to be. Second, to discuss strategies for prevention and recommendations for the selection and use of moisturizers. And I will be sharing a link, and also you will see the consensus document in the chat box down the road a little bit. So you can get the full details by reviewing that entire consensus document, which is something like 20 pages. And then finally, we'll talk about some interventions to encourage patients, families, and caregivers to be involved in the process of managing at-risk skin, and talk about how you can look to some performance improvement projects to implement this in your facility or across your systems. So I'll talk about the background of CARS. I'll give you an overview of the statements. We'll talk about some interventions and strategies, and then we'll have some time for Q&A. So when we were at a long-term care advisory panel meeting at Medline headquarters a couple of years ago, the Medline people shared with us some skincare utilization data that they had developed by looking at a large number of their customer records with utilizations and numbers of patients. And I'll show you these details in a second. What was most troubling about that data was that it showed a significant underutilization of both skin barriers and moisturizers, given the number of patients that were at these various facilities. So a group of us from the Long-Term Care Advisory Board started talking about this and then volunteered to discuss this more and try to figure out what was prompting this underutilization. And that was the birth of our Coalition for At-Risk Skin. So we did a literature review, and ISTAP ended up, and the work that the International Skin Care Advisory Panel, ISTAP, has done, really became our starting point, because they had done a fabulous job in looking at the skin tear issue and identifying all the things that we wanted to do for at-risk skin more broadly. So we wanted to look beyond just skin tears, but the model from ISTAP really was our starting point, and we are grateful to them. So we then decided to do a consensus document where we would talk about key points that we thought were critical for managing at-risk skin. And we developed 24 statements. We aggregated them from amongst the members. We had a meeting in Charlotte, North Carolina to review those statements in 2021. And we determined that 7 out of 9, or 80% votes, were needed to approve each statement. And edits were made and to be made until we reached at least 80% approval. So when we went through the 24 statements, 3 of the 24 were deemed not to qualify really as broad consensus statements. They were too narrow. But 21 of the statements passed with 100%. And the 3 other statements we embedded in the 21 statements. And so then we worked for another year on writing a journal article, and we have many, many other projects planned. So actually, since we wrote the consensus document and started, we have added a few members, and we have a few new positions filled, but Kathy Milne and Monica Progar are co-chairs. I serve as senior advisor. Noreen Nicole, who's a dermatology nurse and Dean Emeritus from the University of Colorado College of Nursing, is our budget coordinator, and 2 of our real dermatology nursing experts, the other being Edna Atwater, who was involved with the Duke University Department of Dermatology. Our other members include people across the continuum of care. We have several physicians. We have a physical therapist. We've recently added Nancy Munoz, a dietitian, and we have 2 Canadians, Kim and Kevin Wu, who I'm sure you know that name. And our hope is to be broadly North American and add a couple of Mexicans and keep a North American focus, since we have many things in common the way we practice in North America. Let me see something here. Okay, nope, I'm going the wrong way. All right. So when Medline analyzed this skincare data, they collected patient days from facilities. Then they pulled sales of moisturizer and skin barriers, and they calculated the results to see what the average usage was per patient day. And you might ask yourself, what's a reasonable number of patient days to be looking at in order to get statistical significance? You might say, well, 5,000, 10,000. Well, here's what they actually looked at. They actually looked at 23,590,802 patients' data and get the outcome. And I'm going to show you next a graph that discusses what they found in terms of utilization. And so we'll look at the left graph first, which is moisturizers. So we established a benchmark of 2 ounces per individual per day as a benchmark for utilization of moisturizers for the average person. And Noreen Nicole helped us do that using some dermatology standard practices for fingertip amounts and for the system of 9s, and to try to determine what an average should be. There really wasn't much in the literature to guide us. So we ended up with 2 ounces being a benchmark. And then when we compared what the Medline customers were using, their average was 0.09 ounces per individual per day, compared to a benchmark of 2. So significant underutilization, only enough, as you see here, to cover one hand. Then we did the same for moisture barriers of incontinent patients, with the assumption that there would be the kind of manufacturing standard of using 4 milliliters 5 times a day for incontinent patients. And so we came up with a benchmark of 0.68 ounces per incontinent individual per day. And when the data was analyzed for Medline customers, the average was 0.11. So it was even more underutilization. Both of these charts make certain assumptions, and much more work needs to be done on looking at these benchmarks for both moisturizers and barriers. And it's great research projects to be done. These are based on an average individual. We have no idea really what the benchmark would be for an obese patient, morbidly obese patient. Obviously, it's going to be much more. So these are all issues that need to be looked at more. So coming out of this deep concern that people were underutilizing product, and as we talk to people and ask them, do you know what 2 ounces of moisturizer looks like? Even some of us on the advisory board weren't sure what 2 ounces was. And that right away is a problem. So that spurred us to write this consensus document, which was published as a supplement here in the US to both wound management and prevention and wounds in November of 2022. And here is a link to the consensus document, but our friends at Medline, Shelley, who's on this call, is going to post that up for you to download. And you can always email me. Feel free to do that if you'd like a copy of the document. So I'm going to review some of the most important of the 21 consensus statements. And we'll start with the definition because that was a real challenge. I mean, it seems sort of obvious what at-risk skin is, but then when you go to define it, it's kind of complicated. So we ended up saying at-risk skin is defined as the potential for impaired barrier function of the skin due to associated intrinsic or extrinsic risk factors, conditions, and comorbidities. So we began to make the list of risk factors that we felt were associated with at-risk skin. And as you can see, there were lots of them. We spent hours looking in the literature to see if we could find a tool that we could use clinically at the bedside for identifying, is this person at risk for at-risk skin? When you Google those, you can come up with the Braden scale for pressure injury. You come up with tools for skin cancer risk. But as far as we can determine, nobody has yet developed kind of the Braden scale for at-risk skin to help us quickly go through a series of questions and say, this person has at-risk skin, is at risk for at-risk skin. It's a real need, and if any of you want to take this project on, it would be a great contribution. But certainly the ones we think of most are incontinence, incontinence-associated dermatitis, obesity, MASD, PPE, device-related medical device-related pressure injuries. But there are just so many more. And chronic illnesses, diabetes, thyroid disease, polypharmacy. These are all issues that contribute to at-risk skin. So one of the things we'll talk about at the end of the presentation is what sort of performance improvement projects could you do in your own facility? But even before that, it's like, can you identify what percentage of your patients, residents have at-risk skin? Have you ever really thought about it? And, you know, when I think about my nursing home here in York that I worked at, it was probably 80% of our residents that at least that had at-risk skin. So we believe that all patients should have an evaluation to determine if they have at-risk skin. And those people who are identified should have an initial comprehensive ongoing assessment to develop care strategies that include prevention and risk mitigation. So let's say you have the incontinent patient who's got cirrhosis, very dry skin coming in, then, you know, initially they would have moisturizer 2 ounces a day and skin barrier up to 5 times a day and PRN as part of their plan of care. And I think we do that sometimes, but we may not do it as systematically as we should be. And certainly in my experience and the experience of many of the CARS members, we're not directing the nurse aides and the nursing staff in terms of how much quantity they should be using. And they do a lot of it's just by either their own feelings about it or what they've learned from another nurse aide who was there before them. But the focus on ingredients and quantity are really something that we need to be thinking about. So let's talk about number 6. Skincare strategies should be personalized based on product properties and ingredients. So there is a wide range of performance among moisturizers. There are lotions, creams, and ointments. They perform very differently. Our recommendation, which I'll go over in a moment, is that creams are the best option for people who have at-risk skin. Lotions can be drying and ointments can be oily and uncomfortable. So our recommendation is 2 ounces per day of creams. So to summarize it all in a nutshell, what we want is for people to have skin like these grapes and not to have skin like these raisins. And it's a perfect summary of how if you keep the skin hydrated and it doesn't dry out like those raisins, then it decreases risk. Now, the science for that is not as great as we would like. And certainly we need more research on how often, how much, which ingredients are best to keep skin, at-risk skin, from breaking down, having skin tears, ending up with pressure injury. But intuitively, clinicians know that healthy skin will be less at risk than dried out raisin skin. So the properties, ingredients, utilization, and intended use of skincare products impact their efficacy. This includes moisturizers and skin barriers. Many of us are using products that we may think are creams and are therapeutic, but in fact, they're lotions. And part of the problem for this is that many skincare products fall under, here in the United States, the US Federal Food and Cosmetic Act of 1938. And they really don't need to have the science to support their claims. So people should be very careful as they evaluate these products and see whether the therapeutic claims are clinically valid and relevant. And I'll give you a couple examples of that. But they're not, most of the moisturizing products are not prescriptive products. And so they don't have the same bar to raise up to in terms of clinical validation for their claims. So again, we recommend that creams or ointments are preferred. Creams is our #1 choice for improving skin barrier function because they decrease transepidermal water loss. Lotions, because their water content, can be drying and therefore may not achieve the same desired effect. So here's an example, just one from every day, of how these products can make claims that can be a little misleading. So if you look at these anti-wrinkle creams, all of them sold as anti-wrinkle, anti-aging creams. You might ask yourself, well, what allows them to make that claim? Well, it's that they contain sunscreen, and that is the ingredient that allows them to call themselves anti-wrinkle, anti-aging. This is probably the most practical information in this talk this evening. So you can pay big bucks for these cosmetics, or you can just get some sunscreen and get a similar effect. So knowing what ingredients are in the products that we use is important. And I don't have time to detail all the different products, ingredients, and what they do, ceramides, humectants, etc. But there are a number of charts in the document that outline what advantages certain products, certain ingredients have for at-risk skin, and also the advantages and disadvantages of lotions, creams, and ointments. So those charts are well worth looking at with the product that you're using in your facility right next to it, so that you can evaluate whether you're using the best product that you can afford. So the next set of statements that we have, 10 through 14, talk about how these moisturizers should be used. So they should be applied daily at a minimum and always after bathing. Twice daily moisturizing has been demonstrated to show additional benefits. But the link with preventing pressure injuries, breakdown, is not as strong as we would like it to be. The appropriate amount needed for a single application of moisturizer to the entire standardized size body is 30 grams or 1 ounce per application. That's 2 ounces per day. And if you just take a look at the size of your moisturizer that you have at bedside in a facility and calculate, well, how many days is that in that one bottle? You'll get some sense of whether you're providing enough at the bedside. Skin barrier products are recommended when moisture, microclimate, friction, and shear are contributing factors to at-risk skin. And our plan is to do our next consensus document looking at skin barrier products, because there's even more confusion about which are the best skin barrier products and how they should be used appropriately. Is it zinc? Is it silicone? How do you remove zinc without doing more tissue trauma? These are the issues that we want to look at in the future. Skin barrier ingredients and individual risk factors, comorbidities, and conditions may vary and therefore impact selection and frequency of application. So obviously, if you have chosen to use an ointment as instead of a cream for moisturizer, and the patient doesn't like the feel of the ointment, then patient preference reigns. And you may have to move down to cream or potentially even a lotion in order to get them to be adherent to the plan of care. So we do know that moisturizers and skin barrier products may have a positive impact on reducing medical device related pressure injury and medical adhesive related skin injury. More study is also warranted here. So this was one of the things that we came up with, because as we started talking to bedside caregivers, we realized that these quantities didn't have any meaning for them. You know, what does 1 ounce of moisturizer look like? So we came up with this enabler that gives an idea of what 1 ounce is, so that people can have it in their mind when they go to the bedside to perform skincare. So 1 ounce is an entire medicine cup, or 4 packs of ketchup, or 3 coffee creamers, or a travel toothpaste. So that, you know, gives people some sense of how much they should be using in order to do a single application. And of course, we recommend twice daily. So we're going to be putting this enabler up on a CARS website as soon as we get mobilized to have our website, which hopefully will be soon. Now, we also gave some thought to special populations and how things may differ with at-risk skin and skin health when you think about special populations. So people who use PPE, this of course became very prominent thought during the pandemic, or perform hand hygiene, may experience at-risk skin and require preventive skin care. So moisturizing the hands after using alcohol rubs. That was something that wasn't really a patient issue until, as much as it is now, until the pandemic. So how do we systematize that to make sure that all those PPE users are not going to be at risk for skin? And then, so people at end of life may experience unavoidable skin changes as well. And palliative interventions for this population may be appropriate, but what should they be? And just as one example, and we're going to explore this some more, but, you know, giving a palliative patient a back rub can be very comforting and reduce pain and suffering. And that's best done with a lotion and not with a cream. So there are specific population health issues that relate to specific population, be they the morbidly obese or the end-of-life patients. And we need to think about this. It's a huge topic that we need to be exploring. And it truly is a resident patient safety issue. And so that's what CARS wants to do moving forward. So it's not just about clinicians at the bedside, but there needs to be organizational support to make all this happen. So we have to educate staff, individuals, families, caregivers on at-risk skin care. We need a commitment from our organization for ongoing performance improvement strategies. related to at-risk skin. We need to first figure out, where are we? Are we underutilizing? By how much? How many at-risk skin patients do we have in our population? What should we be benchmarking to in terms of the amount of product we're buying? And will the organization support that increase in the use of skin products? In the US, those products aren't reimbursed by anybody. So it's a cost that not every organization sees value in yet. We have to make that argument to them. We should have skin health guidelines with a focus on at-risk skin so that it becomes systematized within our system. And then if we do, maybe we can show benefit in terms of finances, regulatory, and legal consequences. If we're doing appropriate at-risk skin management, then maybe our rate of pressure injury will decrease. So this is a lot of good research that needs to be done over time. But before we can do that, we kind of need a tool. So organizations seeking best practices can mitigate risk of at-risk skin through provision and promotion of a quality, standardized formulary with access to non-formulary products if individual needs dictate. I apologize if you hear a squawking bird in the background. He seems to want to join in this conversation. So just a few words about process things. And first of all, these are very US focused, and I don't know how these relate exactly to the Canadian experience. But here in the United States, our Institute of Medicine has defined clinical practice guidelines, and CMS wants our facilities, both acute and long-term care across the continuum, to optimize patient care by having guidelines that are evidence-based. And so that's where we start. In order to promote optimal skin health, you need people involved, you need processes involved, and you need product. They're interdependent. You can't have one without the other. So I mentioned the guidelines, and that's reflected then in policies and procedures and ongoing education of staff. But you also have to buy in from staff and providers. You have to identify who your residents are or patients are at risk. And then you have to have access to appropriate product, the amount and the quantity and the quality that you need. So you can design a performance improvement program for your facility after you get some baseline and see whether, if you introduce at-risk skin moisturization with buy-in from your leadership and guidelines and policies and procedures, then you can get feedback to see whether you are implementing these things properly, and then determine whether you have a decreased incidence of a particular problem. For example, you might focus on incontinence-associated dermatitis, or you may focus on skin tears, and then put the program in place, do a systematic analysis, and see whether you in fact have a decrease in skin tears in your facility. So our CMS, Centers for Medicare and Medicaid, suggests that these performance improvement projects concentrate on a particular problem in one area of the facility or facility-wide. So skin tears, incontinence-associated dermatitis. You implement your protocol, you collect your data, and then you determine whether you've improved the situation or not. So Medline in the United States has suggested that the US used this CMS 672 form to look at data that in long-term care, they're already collecting for CMS. And this is in fact how Medline found a lot of the data they used in their study. You may have something similar in Canada, I don't know. But the CMS 672 is something that long-term care facilities in the United States already have to collect. So that can help them jumpstart on the number of at-risk patients they have. But the clinical conditions that are worth looking at to see whether you can make a difference in terms of implementing a program are MASD, IAD, ITD, medical device-related skin problems, skin tears, pressure injuries. So one other form to show you, and this is one that Medline in the US uses to help its customers identify product utilization and cost based on their census, their aggregate data from that CMS 672 form, and determine where they are in terms of the benchmark and implementing prevention strategies. If you're interested more about this, we can talk about it in the Q&A. Shelley from Medline Canada may be able to add some things about the Canadian perspective. So here is the last and probably the most important of the consensus statements. And that is, everyone should be empowered to perform or receive care to promote optimal skin health. So it's about educating and empowering not just caregivers, but patients and their family members and their caregivers at home. Because optimal skin health really goes across the continuum, but starts with people at home, whether they're young or old or in between. So we need to develop more educational tools for people who have at-risk skin so they know what they can do on their own and be empowered to reduce their risk. So I'm just going to summarize with these 4 statements, and I'll read them to you. Persons with at-risk skin will have improved outcomes and enhanced quality of life when individualized skin care strategies with moisturizers and/or skin barriers are used in appropriate quantities. The CARS panel recommends moisturizing with 1 ounce of quality moisturizers. Creams are preferred twice daily. Special attention to populations vulnerable for at-risk skin, which is population health, is a patient-resident safety issue. And finally, everyone should be empowered to perform or receive care to promote optimal skin health. So CARS plans to, in the next year or 2, to develop tools and toolkits based on our first consensus document that we'll put up on our website that you'll be able to download. We want to build a website, and then we're going to start work on a second consensus document on moisture barriers. So with that, I am going to stop my share.
So just Diane, while you're doing that, thank you so much for such a valuable presentation. Always a delight to hear you speak. We have a couple questions that have come in, but I think what I want to start with is number 1, to congratulate cars. I mean, it's a little self-serving because I'm kind of on it now, but I do think that, one of the things is that cars has really highlighted the fact of at-risk skin. Everyone knows I'm very involved with ISTAP as well. And we've just really narrowed in on skin tears. And then we have CPIAP here in Canada, or NPIAP, EPUAP. Everyone focuses on pressure injuries. And then we have diabetes and diabetic foot ulcers. But I really like the fact that we're going back to the basics here, and we're talking about skin and at risk. And I know you and I have had conversations about the fact that doesn't matter where your patient is, we all have skin. So I think that, it's such a valuable tool to really go back to the basics of nursing. So just, and I know this was your brainchild. So really congratulations to you and Kathy on this. And to Medline for really, seeing the value in this and running with it. Now, one thing that comes up is, when we think about at-risk skin and we think about it from different wound etiologies, we always look at white skin. Now, you and I are, hate to say it, are as pale as we can be. And, we know we're both going to get skin tears when we get older. It's going to happen. We have that skin. But can you maybe elaborate a little bit on the importance of looking at skin tones from across the Fitzpatrick skin scale, and skin tool, in terms of how we need to think about at-risk skin differently?
Well, I heard a really incredible presentation, several presentations on this topic at our conference in Las Vegas last week. And, it was so interesting to see pictures of how incontinence associated skin damage looks different in Black skin versus medium tone skin versus light skin, and all of those issues. So I think that we need to collect pictures. We need to educate one another about what to look for. I was interested to see pictures of how different like deep tissue pressure injuries look in Black skin versus medium tone skin versus light tone. So there's a ton of work to be done in this arena. And we need to begin also by educating the students in nursing and medicine about what they should be looking for, and then patients and family members as well. So there is so much work to be done.
I agree. I thought that Barbara Bates Jensen's presentation at WOCN, where she actually, and for those of you who weren't there, she interviewed a group of panel of nurses with a broad spectrum of skin tones, and they all talked about recent bruises they'd had themselves. And just, from BBJ talking about what a bruise looks like on her, some of her panel members, all of whom had varying skin tones. And it was really interesting to hear how they described just their own personal bruises and what they look like. I get a bruise, everybody knows it. It's like immediately you see a bruise there, versus the fact that some of her panelists talked about sometimes it can take a couple of days, and it's only when it starts turning greenish that they actually really can appreciate the bruise. I found that really fascinating. And I think you're right. We do have a lot of work to do in that area.
So our CARS panel started out with all female white nurses. It's just the way we volunteered. So we've now broadened to have a diversity of different skin tones. And we're going to hope that that broadens our perspective, and we can do some meaningful work on this issue for assessment, because it's critical. Yeah.
I totally agree. And I really look forward to moving forward with that work. Now, changing focus, we have some really good questions that have come in. So one that I get asked a lot, and I'm going to throw you on the hot seat: why lotions rather than creams? Or why creams and lotions? What about ointments? What's better and why?
Well, the CARS panel, and there's a long technical discussion of this in the CARS document, But the CARS panel felt that lotions, because of their water content, which then evaporates, ends up drying the skin more than creams. So dermatology, as a rule, prefers creams because they feel that creams are the best for promoting moisture retention, avoiding transepidermal water loss. And the problem with ointments is that most people don't like ointments. They don't like the feel of ointments. They're sticky, they're uncomfortable. So that's how we landed at creams as the preferred vehicle, with the understanding that individual preference, evidence-based medicine with individual preference will always reign. So if a patient insists on on an ointment, then we'll change the plan of care to an ointment.
No, and I think, you raise a really good point. And certainly the literature supports that lotions are for comfort, moisturizers are for donating and retaining moisture. Ointments do a better job of donating and retaining moisture, and they have the benefit that because they're normally a petrolatum based, that they don't have the additives that may cause a contact dermatitis. However, as you said, they're sticky, they're messy, so we have to be cognizant of that as well. A lot of them will, if we're using them, say, in combination with the absorbent body-worn absorbent products, they can actually clog the briefs and then cause, actually potentiate incontinence-associated dermatitis rather than preventing. So, I think you're right. We have to look at, what's the evidence and what's the best product for our patient at that time. And in some cases, what can your patient afford? Right? Depending on where we live in socialized medicine here in Canada, where a lot of things are covered, but if you're in home care, they're not. So if, for those on the call who work in long-term care, continuum care, or acute care, they're thinking, what's the problem? I'll go in and grab my tube of remedy off the shelf and off I go. But the reality is that in home care, we don't have that luxury. So I think, it's a good point. And, I know that, a lot of people will go, that's not what I want, something more specific. Another thing that's come up is someone asked, where does silicone fit in with this? And my understanding is silicones fall in under the moisturizer category.
Silicones are mostly used in the moisture barrier for incontinence and not for skin care, not for pure at-risk skin care.
Many facilities in Canada do use them for moisturizers as well, simply because we're told we can only have one product on formulary. So what's happening is the MAPWCA are picking the silicone-based products because we can basically do 2 for 1. Otherwise, we have to give up our silicone product.
I get it. So that doesn't, in the US, where none of this is covered at all in long-term care, home care, and in hospitals, then we differentiate because the silicone products are more expensive.
And the individual has to pay for them. So another question from Nancy. Hi, Nancy. Nancy Schutenbelt from New Brunswick said, should we focus on nutrition and the importance of hydration?
Absolutely. And, there's no question that our very narrow focus on topical treatment for at-risk skin doesn't begin to touch all the other things that we have to do to optimize the person's skin, hydrating them, nutrition, medications. We may need to look at their list of medications to see whether those need to be tweaked if they've got a significant at-risk skin problem. So this is just a small piece of a big puzzle.
Yeah. You and I have talked about this before. I think, when we're looking at risk skin, especially when we put on our continence hats, one of the things people often forget to do is that med review. And how many times have you gone in to see someone, particularly in an aged care home or long-term care, and they have massive, irritant dermatitis, and the reality is they're on 4 different laxatives and stool softeners because were on narcotics 6 months ago and nobody stopped those medications, but they've then stopped the medications that were making them constipated, and now they're oozing stool constantly.
Yeah. So a holistic perspective is critical. And of course, that takes time and expertise. And, a lot of patients don't get that done, which is tragic.
It is. Just today in long-term care, I saw an individual who had irritant contact dermatitis, basically, their entire backside, and they've been oozing stool for 6 months, did the med review, and, 3 different laxatives and a stool softener, has been since they came home back to the home from after fracturing their hip. They were in acute care. But, we don't just stop those medications randomly either. There's that comprehensive assessment that includes a rectal exam to make sure they're not impacted of stool. So, there's a lot that goes into to continence care and that protection of the skin.
Yeah, so we're going to try to address all those moisture barrier and continence issues in our next consensus statement, which is it's going to be much more involved, and there's much more diversity in practice for incontinence management than there is for just regular at-risk skin prevention.
And I think a lot of people aren't quite clear on the scope of practice for nurses, depending on what type of nurse they are, where they work in the continuum of care, what the local legislation and policy is. So there's a lot of things that can go into what you can and cannot do and who should be doing it. So I think people often don't realize how complex continence is. So I'm really looking forward to the next document. We have time for one more question, and what's come in is sometimes these creams come in contact with open wounds. Can it interfere with wound healing or be a medium for infection? And do you have any preferred creams, or can any cream work?
So I think that's a really good question about whether if creams get into a wound area, whether there can be anything damaging or not. My suspicion is that with the new generation of creams that we have and products that don't have a lot of fragrance and extra things added, that they're much safer to use and would be less risky than some of the things in the old days. But I don't know, Kim, do you have a thought on that one?
Well, I think certainly, we like to avoid putting these kind of products into wounds. It's off-label use. These moisturizers and lotions are meant to be used on intact skin. So we need to, there's a reason for that. So I think, we need to try and be careful that we're protecting that peri-wound skin, but at the same time, we're protecting our wound. So, and this is where some of the liquid film barriers can come in handy to protect that peri-wound skin. But, it's a matter of, as you said, with the new advances, they're less likely to cause a problem should they get into the wound. But we have to remember that it is off-label use, so we shouldn't actively be putting them into wounds.
Yeah.
I love the question of what's your favorite cream or barrier. We all have them, but a lot of it comes down to what we're exposed to and what's on formulary where we work.
Well, and it reminds me of when I first started going to an image consultant to get makeup done, and she taught me my first skin care for makeup and cosmetics. She always said it's not so much about the product, it's the regularity with which you use the product. And I really, truly believe that. that whether it's a $1,000 cream that you're using on your face or a $100 cream or a $25 cream from just the local drugstore, it's the fact that you're using it consistently. I think that makes a difference both in cosmetic skincare and the skincare we do for our patients.
You know, I think that that's a really good closing point, and something, you know, good takeaway. We know from the skincare world, twice daily moisturizing, you know, does prevent skin tears, but you have to do it regularly. And the same thing is, you know, moisturizing the skin. It's the best moisturizer is the one the patient's going to use on a regular basis. With that, I would like to thank you so much, Diane, for joining us this evening. I would like to as well put a huge thank you out to the Medline crew for sponsoring this session and for providing us with the opportunity to really, right from helping us the establishment of CARS to helping us disseminate this information. So thank you so much to Medline for your ongoing continual support and for bringing us one of my nursing heroes this evening. So thank you all very much for joining us. Please complete your survey. You should receive an email link for the survey, for the post-webinar survey. And if you have any questions, please feel free to email us and we will pass them along to either Medline or Diane, depending on the question. If you have product-specific questions around Medline products, please reach out to us and we will make sure you get in contact with your Medline representative. And look forward to please keep an eye out for our next CARS documents that hopefully we'll get started on soon. So thanks everyone and have a good evening.
Thank you, Diane, and thank you, Kim.